Hi guys! For today, we're kicking off one of the most foundational and sought-after subjects in pharmacy. That is, pharmacology. So, let's dive in. Pharmacology is the branch of medicine and biology that focuses on the study of drug action, or how the drugs interact with biological systems to produce effects. A drug can be anything, synthetic, natural, or endogenous, that produces a biochemical or physiological effect on cells, tissues, organs, or even the whole body. It helps us understand not only how drugs work therapeutically, but also their adverse effects and toxicities. The scope of pharmacology is vast, ranging from molecular interactions to clinical applications, and involves various subdisciplines. But for today, we will focus on one of its core pillars, the pharmacokinetics. Pharmacokinetics is a fundamental concept in pharmacology that describes how the body interacts with a drug, or, as the most of us say, what the body does to the drug. It describes how drugs are absorbed, distributed, metabolized, and excreted, summarized with the acronym ADME or ADME. Understanding pharmacokinetics is crucial for optimizing drug dosages, minimizing side effects, predicting drug interactions, and ensuring the safety and efficacy of therapeutic interventions. So first up, absorption. In pharmacokinetics, absorption is the process by which a drug moves from its site of administration into the bloodstream or your systemic circulation. So think of it as the drug entering the body's highway system. Now, the way a drug is taken significantly affects its absorption. For example, you'll take the drug orally or by mouth, the most common route of administration in the form of tablets, capsules, or liquids. But here's the catch. The drug has to survive the stomach acid, get absorbed through the intestines, and then more importantly, it goes straight into the liver first. This leads us to the concept of first-pass metabolism. First-pass metabolism, or we also call it the first-pass effect or the pre-systemic metabolism, refers to the initial breakdown of a drug by enzymes in the liver or in the intestinal wall before it reaches the systemic circulation. It significantly affects the drug's bioavailability or the fraction of the drug that enters the bloodstream unchanged. So, when you swallow a pill, it travels through the esophagus, into the stomach, and to the small intestine. And absorption mainly occurs in the small intestine. And from there, blood carrying the drug enters the hepatic portal vein, going directly to the liver. The liver metabolizes the drug, and some of it may be inactivated or altered. And the result is, even the drug is well absorbed, much of it may be lost during the first pass effect. And then again, aside from the liver, first pass effect can also occur in the intestinal mucosa or the gut wall. First pass effect can reduce the active drug reaching the systemic circulation, can decrease the bioavailability, and for some drugs may be almost completely inactivated on first pass. Now let's go to another route, the intravenous or IV route, which is the administration of the drug directly through the veins. This means that there is no absorption phase and the drug is immediately in the bloodstream, meaning there is a 100% bioavailability. Some other routes of administration include intramuscular, transdermal, subcutaneous, rectal, inhalation, sublingual, and buccal. Let's go to another factor that affects the absorption, which is the drug properties. Drugs that are lipid-soluble pass more easily through the cell membranes. Think of it this way. The more a drug likes fat, it better crosses the barrier into the bloodstream. For example, lipid-soluble drugs like diazepam have an excellent absorption. Another one is the molecular size. Generally, the smaller the molecule, the faster and more efficient it can pass through the membrane. The next one is the ionization state, or the pKa and pH. Weak acids are better absorbed in acidic environments like the stomach because they are mostly unionized there. Weak bases are better absorbed in alkaline environments like the small intestine where they remain unionized. Why does this matter? Because only unionized or non-charged molecules can easily cross the membranes. And this is described by the Henderson-Hasselbalch equation, which tells us how much of the drug in its ionized versus unionized form depending on the pKa of the drug and the pH of the environment. Lastly, The physical form of the drug also plays a big role in how fast and how much it gets absorbed. Let me give you a few examples. Solutions are already dissolved, so they are absorbed the fastest. Suspensions take a little bit longer because they need to dissolve. Tablets and capsules need to break apart first before the drug can dissolve and be absorbed. Enteric-coated tablets are designed to resist stomach acid and only dissolve in the small intestine, delaying the absorption. And some extended-release formulations are made to release the drug slowly over time. The next factor are the physiological factors such as the gastric emptying rate, gastrointestinal motility, blood flow to the absorption site, the surface area, the presence of food, the gut microbiota, and the transporters such as the P-glycoproteins. And lastly, the bioavailability. Again, bioavailability is the proportion of an administered drug that reaches the stomach circulation unchanged. And to get the bioavailability for oral drugs, the equation is the area under curve of the oral drug over the area under curve of the IV times 100%. The area under curve reflects the total drug exposure over time. And the factors that reduce bioavailability include incomplete absorption, the first-pass metabolism, the drug degradation in the GI tract, and some drug interactions. Now that we've covered the A in ADME, let's move forward to the next important phase, which is the distribution. Distribution refers to the reversible movement of a drug from systemic circulation or your bloodstream to the various tissues and organs in the body. In simpler terms, once the drug has entered the bloodstream, it doesn't just stay there. It begins to travel, being delivered to tissues like your brain, liver, muscles, or even fat, depending on the few key factors. But here's the catch. Not all tissues receive the drug at the same rate, and not all drugs distribute in the same way. So let's break this down. Let's discuss the factors that affect the drug distribution. Let's start with the blood flow to the tissues. So, organs with high blood flow like the brain, liver, kidneys, and heart receive drugs faster and in greater amounts. Meanwhile, the less perfused tissues such as fat, skin, muscle, and bone receive drugs more slowly. This is why the drugs targeting the brain or kidneys tend to act more rapidly than those that act on muscles or fat. Another factor is the lipid solubility of the drug. Highly lipid-soluble drugs can easily cross the cell membranes, which are made up of lipid bilayers, and these drugs are more likely to enter fatty tissues or even cross protective barriers like the blood-brain barrier or the BBB. For example, drugs like thiopental, which is a barbiturate, rapidly enter the brain due to their high lipid solubility and making them ideal for inducing anesthesia. Another one is the plasma protein binding. So in the bloodstream, drugs can bind to plasma proteins, especially albumin for acidic drugs and alpha-1 acid glycoprotein for basic drugs. But here's the key. Only the unbound or free form of the drug is active, meaning it can cross membranes, bind to receptors, be metabolized, and be excreted. High protein binding means less free drug available for action, longer duration of effect since the bound drug acts as a reservoir, and potential drug interactions if another drug displaces it from the binding site. And another factor is the tissue and membrane permeability. Not all tissues are equally accessible to drugs. This depends on capillary structure and specialized barriers. So we have loose capillaries like those in the liver or spleen that allow easier passage, and we also have tight capillaries like those in the brain which restricts movement. And we also have the blood-brain barrier, which is a highly selective barrier made of tight junctions and astrocytes, and only a small, non-polar, lipid-soluble drugs can passively diffuse across. And drugs may also require specific transport proteins. P-glycoprotein is an efflux transporter in the BBB that pumps certain drugs back into the blood, limiting brain access. So this is crucial when designing drugs for central nervous system conditions like epilepsy or depression. And then we also have the placental barrier. So it is not a perfect barrier because many drugs can cross and potentially affect the fetus, and lipid-soluble and unbound drugs cross more easily. And because of this, it is always important to consider in pregnancy pharmacotherapy. Now, Let's discuss a key pharmacokinetic parameter used to quantify distribution, the volume of distribution or the VD. VD is a theoretical volume that tells us how extensively a drug distributes throughout the body, and the formula for it is the amount of drug in the body over the plasma drug concentration. You have to remember that it is not an actual anatomical volume, but rather a mathematical value used to understand a drug behavior. So how do we interpret the VD? The low VD, which is around 3 to 5 liters, means the drug stays mostly in the plasma, and it is common for large polar or highly protein-bound drugs. For example, heparin, which is a large molecule. And the high volume distribution, which is about 40 to 50 liters, indicates extensive tissue distribution. It suggests that the drug may accumulate in fat or muscle or cross into cells. And it's common for lipophilic or tissue-binding drugs. For example, digoxin that binds to cardiac and skeletal muscle. Volume of distribution or VD is used to calculate the loading dose. And it's especially important for drugs with long half-lives where there is a need to quickly achieve therapeutic levels. Now let's move on to metabolism, or also known as biotransformation. It is the process by which the body chemically alters the drug, usually to make it more polar and water-soluble, allowing it to be more easily excreted, typically via kidneys. Think of it as the body's way of preparing a drug elimination, like tagging it with a signal saying, "Time to go." The primary site of metabolism is the liver, specifically in liver cells or hepatocytes. But metabolism also takes place in other tissues such as the intestinal wall, kidneys, lungs, plasma, and the skin. And drug metabolism typically occurs in two major phases, phase 1 and phase 2. Let's break each other down. Phase 1 reactions or functionalization reactions are modification reactions. The body introduces or exposes a functional group on the drug molecule. And the common phase 1 reactions include oxidation, reduction, and hydrolysis. The purpose of it is to make the drug more polar and often prepare it for phase 2. And these reactions can result in activation, which is rare, inactivation, or sometimes a drug becomes more toxic. The cytochrome P450 enzymes or CYP450s are the main enzymes involved in the phase 1 metabolism. It is located in the smooth endoplasmic reticulum of liver cells, and it is composed of various isoenzymes, each with specific roles and drug targets. And the notable CYP isoenzymes include CYP3A4, which is the most abundant and metabolizes around 50% of all drugs, but we also have CYP2D6, CYP2C9, and CYP1A2. Some drugs can modify the activity of these enzymes, and this is critical in understanding drug interactions. There are drugs that produces enzyme induction or increases the amount or activity of the CYP enzymes, and this results in faster drug metabolism, and also can lead to reduced drug effectiveness. For example, we have these drugs here. There are also drugs that decreases enzyme activity, which leads to slower metabolism, longer duration of action, and higher risk of toxicity. And these are the following examples. Again, this is the major cause of clinically significant drug interactions, especially with drugs that have a narrow therapeutic window. Now let's go to phase 2 reactions or the conjugation reactions. In this phase, the drug or its phase 1 metabolite is conjugated with an endogenous molecule, making it even more water-soluble. And the common conjugating groups include glucuronic acid, sulfate, acetate, and glutathione. And the enzymes involved in this include UDP glucuronosyl transferases, sulfonotransferases, N-acetyltransferases, and glutathione S transferases. And the end goal is to create a metabolite, again, that is inactive, non-toxic, and easily excretable. Now, some drugs are administered in an inactive form. We call it a prodrug, and it must be metabolized into their active form. This means that metabolism is not always about inactivation. It can be essential for drug activation in some cases. Now, we also have to know that metabolism isn't the same for everyone. And there are a lot of factors affecting drug metabolism. For example, genetic polymorphisms. Variations in genes coding for enzymes like CYP2D6 affect how people metabolize certain drugs. Individuals may be poor metabolizers, where the drugs may accumulate leading to toxicity. There are also people that are considered ultra-rapid metabolizers, where the drug clears too fast, leading to a reduced effect. It is more discussed in pharmacogenomics. Another factor is the age. Neonates and infants have immature liver enzyme systems, which leads to slower metabolism. And elderly, because of the possible decline in liver function and hepatic blood flow, can also lead to altered metabolism. Disease states is also a factor, like liver diseases, which impair metabolism, and heart failure, which can reduce liver perfusion, decreasing metabolic capacity. Another factor is the drug interaction. So co-administered drugs can induce or inhibit metabolism, as I have mentioned a while ago. And also, diet and environment can also affect drug metabolism. There are certain foods such as grapefruit that inhibit CYP3A4, the cruciferous vegetables which can induce enzymes. Smoking also induces CYP1A2, which affects the metabolism of drugs like theophylline or clozapine. And that includes the M in ADME, metabolism. And now we have reached the final phase of it, which is the elimination or excretion. Excretion refers to the irreversible removal of a drug or its metabolites from the body. In simple terms, the final exit point of the drug. The kidneys are the main organ responsible for eliminating most drugs and their water-soluble metabolites, especially those that have been modified in the liver to become more polar. But there are other excretory routes such as the bile into feces, especially for large and conjugated molecules, the lungs for volatile compounds and anesthetics, the sweat and saliva as minor routes, and the breast milk, which is important in nursing mothers because lipophilic drugs can pass to infants. The drug elimination via the kidneys occurs in three major steps. Glomerular filtration, which occurs at the Bowman's capsule, and only free or unbound drugs in the plasma are filtered. It is dependent on the GFR or the glomerular filtration rate. Drugs bound to plasma proteins like albumin are not filtered. Another one is the active tubular secretion, which takes place in the proximal tubules. It involves active transport via carrier proteins like organic anion transporters and organic cation transporters, and it can eliminate both free and protein-bound drugs. It can be saturated or inhibited by other drugs though, which is important to consider in drug-drug interactions. And then another one is the tubular reabsorption, which happens mostly in the distal tubule. This is a passive process where non-ionized, lipid-soluble drugs can diffuse back into the bloodstream. And urine pH plays a major role here. And this is clinically important because we can alter the urinary pH to enhance the excretion of certain drugs. For example, alkalinizing the urine with sodium bicarbonate increases the excretion of weak acids, like aspirin. Or, acidifying the urine with ammonium chloride increases the excretion of weak bases, like amphetamines. Now, some drugs, especially the large polar compounds, are excreted via the bile into the intestines. For example, the steroid hormones or the glucuronide conjugates. And these drugs may then be excreted in the feces or reabsorbed from the intestines, entering a cycle called enterohepatic recirculation. And this can prolong the drug's half-life and delay clearance. For example, oral contraceptives or digoxin. Clearance is a key pharmacokinetic concept that tells us how efficiently the body removes a drug. Clearance, or CL, is the volume of a plasma from which a drug is completely removed per unit time. And the formula for it is rate of elimination over the plasma drug concentration. And it's affected by renal, hepatic, and other organ clearances. Clearance is also important to determine the half-life. And the formula for it is 0.693 times the volume of distribution over the clearance. And this relationship shows how the clearance and volume of distribution influence how long a drug stays in the body. Clearance is used to calculate maintenance doses, design dosing intervals, and determine if a drug will accumulate in patients with renal or hepatic impairment. And that's all for ADME. Now, let's discuss the mathematical models used to represent how drugs move through the body. We have the one-compartment model, which is the simplest model. It assumes that the entire body is in one uniform compartment where the drug distributes instantly and evenly, and it is suitable for small, water-soluble drugs with fast distribution. Two-compartment model is more realistic. It divides the body into central compartment, the blood, the highly perfused organs, and a peripheral compartment, which comprised of less perfused tissues. It explains the distribution phase and the elimination phase. And then also we have the multi-compartment models. It is used for drugs with complex distribution where the different tissues absorb and release drugs at different rates. Now, let's bring all this into clinical practice. How do we use pharmacokinetics to optimize therapy? First, we use it for dose regimen design. We use it to get the loading dose, the maintenance dose, and the dosing interval. Also, pharmacokinetics is important in therapeutic drug monitoring, which involves measuring plasma concentrations of drugs to individualize dosing. And this is essential for drugs with narrow therapeutic index. Also, pharmacokinetics is important for individualized therapy. So it is used to adjust dosing based on the renal impairment, hepatic impairment, age, genetic polymorphisms, and drug interactions. Pharmacokinetics is also essential in drug development, in preclinical and clinical trials, determining the dosing regimens, evaluating the bioavailability, half-life, and toxicity risk of a drug, and of course, identifying drug interactions. In conclusion, pharmacokinetics is more than just ADME. It is a scientific framework that guides the safe and effective use of drugs. A thorough understanding of absorption, distribution, metabolism, and excretion helps us answer the questions like how much drug should we give, how often, what happens if the patient has kidney or liver disease, or will this drug interact with others? So to wrap up, pharmacokinetics is a patient-centered science. It's how we maximize efficacy, minimize toxicity, and tailor treatment to the individual. It is the foundation of rational drug therapy, and it's essential for every pharmacist, prescriber, or healthcare professional. For our next topic, we will discuss pharmacodynamics. And with that, we thank you. I hope you learned a lot about pharmacokinetics. And if you have questions, suggestions, corrections, or additional information, feel free to put that on the comments so that we can discuss it. See you next time.